Hello, I'm Janice Karen, Director of Policy, Technology, and Innovation at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. All right, let's go to the first update. So the first thing is that ONC has a new blog post that they've put out about the TEFCA fire roadmap. We've talked about this a few times. They focus a bit on the first phase, which is consistent with the information that we've previously gotten. That first phase will be what they're calling facilitated fire, which is basically using TEFCA as a fire endpoint directory. Its availability is tied to the availability of the Common Agreement version 2. The last update from Sequoia said that the Common Agreement version 2 was coming out in Q1 2024. The last update from ONC specifically on this topic said spring. And what ONC said in this blog post was possibly as soon as Q1. So the exact timing is still a little bit up in the air. And that's just when it's technically feasible to start doing this. That doesn't mean that anyone will have it turned on the moment that gets released. Then after the facilitated fire phase, there will be the next phase that they're going to implement is QHIN to QHIN exchange via fire. And then after that's fully operational, there would be a more direct fire exchange between participants or between participants and QHINs. And that's actually a little bit of news because there was some question about whether that was even fully in the works. So that's what the current plan that this blog piece has. You can follow the link and read it for yourself. Anyone have any questions or comments? Any thoughts they'd like to share with the group? All right, moving on to the next item then. So CMS has put up some draft guidance on ECQMs, two different pieces of guidance. The first one is on how to read the ECQMs, and then the second one is on the logic and implementation of ECQMs. So the comment window for these is very short. Excuse me. It closes on January 23rd. The reading guidance is very short. It's only 5 pages long, and it covers basically packages, the building blocks, and how to understand the human readable HTML format. So it's basically about how to understand what you get when you're handed an ECQM. And then the second piece of guidance on logic and implementation is more about how the measures are actually implemented and what they entail. And so that has 3 main areas of focus: the resources involved, CQL measure logic, and then the data elements and value sets. So you can find the 2 draft guidances at the links there. You'll notice that's actually the ONC JIRA, and that's also how the comments will be left for these. So inside the JIRA tickets, each of those is a JIRA ticket. You may have to sign up for a free account to have full access. And inside there's a link to a downloadable PDF, as well as a place to have discussion and instructions on how to comment. Any questions or thoughts or comments there? All right, moving on then. The next couple of slides are some Medicaid and CHIP reports and information. So the first thing is that CMS has released a couple of data briefs. The first one is on well child visits for folks under 19. So it goes all the way up through the age of 18 in the year 2020. So obviously that data is expected to be strange, but it didn't really show up that much, other than possibly having, I don't know if 50% is high or low. It didn't seem entirely out of whack to me, to be honest with you. But what was interesting was that 50% of the eligible children received a well child visit. That didn't vary across the different types of insurance. It didn't really vary by the primary language spoken. In fact, English was slightly lower than Spanish or other, but they were all like 49, 51, 52%. Almost all of the numbers in this data brief were like 48 to 52%. So it really was pretty evenly distributed. And you can find the full report with some graphics at the link. So I don't know if anyone has any comments, any thoughts about whether 50% is good or bad. I mean, I know in theory it's bad because we would like everyone to have one, but how that compares to other years and any thoughts on why it might be so even. All right. If no one has any thoughts or comments, let's move on. The second report was about mental health services and substance use disorder services for 2020. And here there was a bit more variation. What they found was that 22% of enrollees received one or both kinds of services, 18% received mental health benefits, and 9% received substance use disorder services. And I thought that was interestingly high. And what they also found was that the use of both services went up by age. So the older the person got, the more likely they were to use the services, and they supplied those three age range. I'm sorry, that should be 19 to 39. That was a typo, my apologies. But they supplied those three age ranges in the report. Slightly more women than men used mental health services, slightly more men than women used substance use disorder services. White enrollees were more likely to use the services than others. American Indian, which is a term that they use in the report. I know we often use Native American instead, but I use their terminology. We're just behind white users, like barely behind in total. And the lightest users were Asian and Pacific Islander. The one real, like, there wasn't a ton of variance. There was some in the details, but the only place where there was an enormous variance was when they looked at different types of enrollees. Disabled enrollees used services almost twice as much as anyone else. So you can find the full brief there. And I don't know if anyone would like to comment or has any thoughts on any of that.
Hi, this is Terry. I'm working in the behavioral health field. None of this is a surprise to me at all. The rates have been climbing, particularly since the pandemic. And also, I don't know exactly how they decided to categorize disabled enrollees, but anyone with a serious mental illness is considered a disability candidate under SSDI. So you're looking at more than physical disabilities.
Oh, so that might be self-selecting into people who are automatically getting mental health services.
It is probably, those folks are probably included in those figures.
Right,
yes.
Gotcha.
Right. The Asian Pacific Islander is also not surprising because there's a cultural bias, both against seeking treatment and also in favor of just tolerating people with differences. So that one's not really surprising either.
Well, thank you for your insight. So does this line up fairly well with what we see in Massachusetts, as far as you can tell? Not to put you on.
It would line up very well with what we see in Massachusetts, yes.
Great. Anyone else want to comment or have any thoughts here?
I have one question. I don't quite understand the bullet that use went up by age in both areas, 12 to 18, 19 to 29, and 40 to 64 range supplied. I don't understand what that.
Sure. Sorry if I didn't explain that well enough. First of all, there was a typo there, which probably is not helping. So what they did was they looked at three age ranges. So they've looked at people who were aged 12 to 18, then aged 19 to 39, and then aged 40 to 64. Remember, this is Medicaid and CHIP. So in theory, although you could be dually eligible, in theory, you go off of 65 and are on Medicare. So they looked at those three age ranges, and what they found was that the lightest use was in the youngest people. And when you got into the middle range, it went up, and then when you went into the highest of the three ranges, it went up again. And those were noticeable, like statistically important changes. Does that help?
Yes, thank you so much.
My pleasure. Anyone else have any comments, thoughts, questions here? All right, then let's move on to the last Medicaid or CHIP item, which is that there is now an interactive website that allows anyone who wants to view data associated with 57 different measures across Medicaid and CHIP. The date of the underlying data varies by measure, although a lot of it seems to be from either 2021 or 2022. And there's 3 different categories that things are split into: what they call program characteristics, healthcare quality performance, and federal and state administration. They didn't go into a lot of detail about exactly how they make that distinction, but I think that certainly a lot of the actual outcome measures would be under healthcare quality performance. And they gave you a lot of different ways to look at individual measures. So you can look by name, you can look by content area, you can search by keyword, you can look at the data sources, you can also look at data availability. So however you get there, when you click on a specific measure, you get to a page that has a ton of useful data. It's a little bit different. I only looked at a handful of the measures. It's a little bit different. So it's whatever data is pertinent for that measure, but there's a bunch of graphs. You can filter on different things depending on what the measure is. So it's really a very useful interactive way to get data about Medicaid and CHIP usage. And you can find it at the link at the bottom of the page. Any thoughts, comments, questions there? All right, then let's move on. So NIST has put out some draft guidance for AI research, and this was part of one of the recent executive orders on AI, and it focuses on de-identifying data while retaining its usefulness, and it's primarily talking about a technique that's called differential privacy. The report is meant to be accessible to non-technical people. It does address both data generated in the health system and patient-generated data. I would say it focuses a little bit more on the patient-generated data, especially at the high level, which I only had a chance to look at it at the high level so far. It is open for comment. The comments are due on January 24th. You can find a press release and the actual guidance at the links there. And I have not had a chance to look at it in excruciating detail, but if anyone has any questions or has any, I'll certainly try to answer them. And if anyone has any other thoughts there, please feel free. All right, then let's go ahead and go to the next slide, please. So I believe this is the last update. In sort of mid to late December, the House passed a bill that has new drug price transparency requirements. It has not yet been taken up in the Senate, so it is not law. There is the general thinking that I saw is that it is likely to pass the Senate, but with some modifications. So you never know until that happens. And it's not clear what may or may not change, but the clauses in the bill as passed by the House include semi-annual PBM reporting on a lot of cost and claims issues, and that reporting is primarily to the payer. But there is also a requirement for PBMs, for some PBMs, and it wasn't clear to me in what I had a chance to look at exactly what their criteria would be, but would need to publicly post their pricing before they could charge patients anything for drugs. There are also some new payment requirements for Medicare and Medicaid in this bill, and also would disallow spread pricing payments under Medicaid. And then there are also some reporting and disclosure requirements for both payers and providers. So it is focused somewhat on PBMs, but it's really about drug price transparency more generally. And again, it is not law. It has not passed the Senate yet. And the expectation is that there will be some changes to it, assuming that it does pass the Senate, and then there'll have to be a reconciliation process at that point between the House and Senate. So this isn't going to be law tomorrow, but the expectation from what I've seen in the couple of articles that I saw is that some form of this is likely to pass. It has bipartisan support, in general, just not necessarily in all of the specifics. So any thoughts, questions, comments there? All right, if you'll go to the next slide and pause there. I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@mahealthdata.org. That email address is also on your screen.